Uh, Now, I would like to welcome our last speaker for today, our dashing ADC, Dr. Vikram Deshmukh, sir. He is a practicing urologist and andrologist at Sri Urology Center, Amravati. He is practicing here since 2013, and we know that he is a pretty good singer. So today he'll be talking on the management of prostate cancer. So over to you, Dr. Vikram, sir.
Thank you, Vikram. Okay, am I audible?
Yes, sir, you are audible, sir.
Yes, sir.
Okay, I'm sharing my screen.
Sir, at the bottom, you can see a green
Yes,
symbol.
yes, I've done it.
Okay.
Can you see my screen?
Yes,
Yes,
sir.
sir.
Okay, so good evening, everybody. Today I'll be speaking on the management of prostate cancer. This is just an overview so that people should understand the basics of prostate cancer. I'm not going too much in detail. So this is the 5th most common cancer worldwide and the 2nd most common cancer in men. Now, as you can see in this picture, the highest incidence in the world is seen in North America, where we have about 250 cases per 1 lakh. And the lowest incidence is seen in Asia, where the incidence is only about 2 cases per 1 lakh. Now, over the last few decades, there has been a shift to a more favorable stage at presentation, which is accounted by PSA screening. Now, though this is true for the Western world, whether this is true for India and Asia is something which I have a doubt. This is the reason is because majority of the patients that we diagnose in India are still diagnosed in an advanced stage. So when we say that we have a low incidence, it actually may be a result of inadequate screening. Now, this is a disease of old age and majority of the patients are diagnosed after the age of 65. And with increasing age, there is a proportional increase in the incidence. Majority of these cancers are sporadic, 15 to 20% are familial or hereditary. Now, familial or hereditary cancers are diagnosed in early age and they are caused by mutations in the cancer-related genes. Now, the etiology of sporadic cancers is not known. However, there are some facts which are clearly established. So what are these facts? One is that prostate cancer is androgen dependent. Androgens are important in development and maintenance of the prostate gland, and exposure to androgen is a prerequisite for prostate cancer to occur in later life. Maintenance of prostate cancer is also dependent on androgens, and this is the reason why androgen deprivation treatment is used in the treatment of advanced prostate malignancies. Estrogen is considered to be protective, and this is the reason why it is used in metastatic prostate cancers. Other factors which confer an increased risk are chronic inflammation of the prostate, leptin, etc. Now, as you all know, adenocarcinoma is the most common pathological type. Majority of the tumor mass is located in the periphery of the gland, and it is multifocal in 85% of the patients. Most common site of metastasis are lymph nodes and bones. Now, presentation is variable. Some patients are identified by screening, while some patients may present with lower urinary tract symptoms. Advanced cases may present with obstructive uropathy and metastasis. Now, for screening, we have to use both the digital rectal examination and serum PSA because detection rates are higher when both are used together than any single test alone. Digital rectal examination alone will miss a substantial proportion of the cancers. Now, who are the candidates for screening? These are men between 50 to 75 years. above 75 years, we should screen only if we have a clinical suspicion of prostate cancer. Now, on digital rectal examination, any nodule, induration, or asymmetry in the prostate should arouse the suspicion of CA prostate. Now, serum PSA is a other important test which we use for screening, and a normal value of serum PSA is considered to be less than 4 nanogram per ml. Now, this should not be used as an absolute cutoff because serum PSA is influenced by many factors. For example, there is an age-related rise in serum PSA of about 0.04% per year. Hence, a patient between the age of 60 to 70 years, for him, a PSA of up to 6.2 nanogram will be considered as normal for his age. PSA is also affected by the gland size of the prostate. This is because PSA is a normal secretory product of the prostate gland, and benign prostatic tissue also secretes PSA. In fact, cancerous tissue secretes less PSA, but we get a higher value in the serum of PSA in cancer because of the distortion in the cellular architecture in cancer leads to leak of the PSA into the blood. And this is the reason why we get a higher value in the serum in cancer. But the benign prostatic tissue is also secreting the PSA. So if we want to find out what is a normal PSA value for a particular gland size, we have to multiply the gland size by 0.15, which is the PSA density. And if the level is higher than this value, then only we should suspect prostate cancer. For example, if the patient is having a 60 gram prostate, a PSA of up to 9 nanogram per ml will be normal for this gland size. Now, there are other factors which can affect PSA. For example, any prostatic disease like prostatitis, CA prostate, benign prostatic hyperplasia can also lead to rise in PSA. We must understand that PSA is organ specific, not cancer specific. It will rise in any disease of the prostate. It is also seen that when patients have acute retention of urine, which is caused by prostatic infection, PSA may be high on the higher side. Any instrumentation of the lower urinary tract, for example, perurethral catheterization, prostatic biopsy, TURP, all these may lead to a rise in PSA. So if we have any patient in whom there is a if he has any of these factors which can lead to a rise in PSA, there is a recommended waiting period where we should do the PSA. For example, if the patient has undergone a catheterization, we have to wait for 7 days before we do a PSA. If he has a acute urinary retention, we have to wait for 3 weeks. If he has undergone a prostatic biopsy, 4 weeks. We must understand that even if we get a higher value of PSA, we have to wait for this recommended period. We have to repeat a PSA, and then only if we have a suspicion, then we should investigate further. Now, 5-alpha reductase inhibitors like finasteride and dutasteride also reduce PSA by 50% at 6 months. So we have to do a baseline PSA before starting these drugs. Now, whenever we have a suspicion of CA prostate, and this has to be confirmed by a TRUS-guided prostate biopsy. TRUS is transrectal ultrasound guided biopsy. This will confirm our diagnosis by histopathological examination, and a minimum 12-core biopsy is recommended. Now, somebody may ask, why should we do TRUS? Why not do a finger-guided biopsy? Because availability of TRUS is a problem. It is not available in all cities. Somebody may also ask, why should we do a 12-core biopsy? Why not do the 6-core biopsy? Some majority of the people in remote centers are still carrying on with finger-guided biopsy, so they may take 6 cores, 8 cores. So why 12 cores? So first I will answer why TRUS. So whenever we do prostatic biopsy, the whole of the prostate has to be systematically biopsied so that we do not miss any part of the prostate. Again, if you have a suspicious lesion identified on TRUS, it has to be targeted specifically. So this is possible only with image guidance. Why 12 cores? Is because a 12-core biopsy will have the maximum cancer detection rate of 30%. We know this by clinical trials. If we take less number of cores, the cancer detection rate decreases. If we take more number of cores, then the cancer detection rate remains the same, but the morbidity of the procedure increases. Now, the trust-guided biopsy will give us the lesions grading, which is important in deciding further management. Now, I won't go into the staging because this is theoretical. Now, we must understand that for staging, we need the information from digital examination, serum PSA value, and the imaging studies. We must understand that imaging studies have their limitations. Extra prostatic spread is something which is not very accurately seen on imaging studies. So we have to use other methods to find out the staging. I'll come to that later. So once we have the investigations done, then we can divide the patients into 3 categories. One is organ confined CA prostate, second is locally advanced CA prostate, and third is metastatic CA prostate. Now we must know that CA prostate is a slowly growing cancer, and average doubling time is about 2 to 4 years. And if we want to give curative treatment to the patients, the cancers have to be identified in early stage, that is organ confined stage. Once the patient is having locally advanced or metastatic prostate cancer, we can only offer palliative treatment. Now, if the patient is identified early by screening, and if the cancer is found to be organ confined, and the treatment options are radical prostatectomy, radiation therapy, and active surveillance. Now, radical prostatectomy is considered as the gold standard treatment for organ confined tumors because it offers the possibility of cure. It is more effective in achieving long-term progression-free survival. It provides accurate staging. Treatment failure is readily identified and mortality is rare. Now, for the patient to undergo radical prostatectomy, he should have a good life expectancy, and the tumor must be biologically significant and completely resectable. And obviously, the patient has to be medically fit to undergo the surgery. Second treatment is radiation therapy. Now, the outcomes of radiation therapy are reported to be comparable to those of radical prostatectomy. However, evaluation of the outcome is more complicated. Biochemical endpoint used to determine treatment success is controversial. Now, why am I saying this is because when we give radiation therapy, the outcome is assessed either by serum PSA or by doing prostatic biopsies. This is how we would find whether the patient is having a recurrence or not. Now, the problem with serum PSA estimation while the patient is undergoing radiation is that the PSA will fluctuate because of the radiation effect. So it takes about 2 years to know whether our treatment has succeeded or not, because that is the time when the PSA value will be more accurate in predicting the recurrence. If we try to do the biopsy, then because of the radiation effect, interpretation of the biases is difficult. So it takes about 2 years to know whether we have succeeded the treatment or not. But from the clinical trials, we know that radiation treatment has almost similar outcomes to radical prostatectomy, so it can be offered to patients. Third option for organ confined tumors is active surveillance. Now, by definition, this means that we are delaying the primary treatment if there is biochemical or histological progression, that is cancer progression, then only the primary treatment is given. Primary treatment is radiation therapy or radical prostatectomy. So why should we do active surveillance is because many prostate cancers are not very aggressive, and if the patient is having organ confined tumors, if he has low life expectancy, if we have a well differentiated tumor, if the core involvement is less. So if we overall find that the tumor is seen to be less aggressive in these patients, but we can try to avoid over treating these patients, and we can put them on active surveillance. And we then intervene only if we find that the PSA is rising, or if clinically we are suspecting that there is a tumor progression. So for this, we need to do digital examination, PSA 3 monthly, and biopsy every year. So advantages over treatment is avoided, and the definitive treatment is effective for majority of the patients with signs of progression. The disadvantage is that it increases the anxiety, and window of opportunity for cure may be missed, and attempts at nerve sparing surgery may also be missed. Now, second category is locally advanced tumors. Now, these are 10% of the newly diagnosed cases. Now, we must understand that many patients who are thought to have organ confined CA prostate actually have locally advanced tumors. This is because the imaging modalities like CT, MRI have a limited role in identifying extra prostatic spread. So they may go wrong when you think that it is organ confined tumor. It actually may be a locally advanced tumor. So any patient who is having a locally advanced tumor or organ confined tumor, supposed to be an organ confined tumor, they should undergo risk stratification. For example, a D-amico risk stratification is commonly used, where we use serum PSA value, Gleason score, and stage, and patients are then categorized into low, intermediate, and high risk. Now, risk here basically means risk of having an advanced tumor. So when we are or when we think that the patient has an organ confined tumor, and if we do the risk stratification, and if he comes in high or intermediate risk, so he is basically not considered as a ideal candidate to be treated as an organ confined tumor. He's taken as a candidate who is in all probabilities having a aggressive tumor, and in these patients we do not offer them definitive treatment like radical prostatectomy or radiation therapy, because they are most likely going to have biological relapse. So in these patients, we should use combined modality treatment. That is, if we are doing radiation therapy, we combine it with androgen deprivation treatment. That is, we give systemic treatment for us to avoid biochemical relapse. So coming to the third and last category, that is metastatic CA prostate. Now, this is a systemic disease. We can identify the the metastasis either by doing a PET scan, PSMA PET scan, or bone scans. And for these patients, we have to use systemic treatment. So first, what we do is we do androgen deprivation treatment, because as I've already told that all these prostate cancers are dependent on androgens. So we have to remove their primary source of spread. So androgen deprivation treatment is the basic treatment for systemic control of CA prostate. It basically means castration, which can either be surgical or chemical. Now, although androgen deprivation treatment is extremely effective initially, all of these patients eventually land up with a castrate-resistant prostate cancer. So approximately after 1 or 2 years, even if you have done a castration, the patient will start showing evidence of biochemical relapse. The PSA will start rising. And this is the reason why all patients of metastatic tumor have to be closely followed. They have to be put on surveillance. 3 monthly PSA clinical examination have to be done. And once we see that there is a biochemical relapse, then we have to put them on anti-androgens. Other treatments can also be given, like abiraterone acetate, and in late stages, or if the patient is having symptoms of metastasis, then chemotherapy is given. We have to understand that patients of CA prostate commonly have bone metastasis, and they may land up with complications of the spine. For example, cord compression is the most common and devastating complication, and it is an oncological emergency. In the initial stage, when if we give steroids, then the patients can they may not undergo any irreversible changes like cord ischemia. And in these patients, if we intervene early, we may avoid paraplegia and other disastrous complications. So any patient in whom we suspect cord compressions has to be put on steroids, an MRI of the spine has to be done, and androgen deprivation, that is castration, has to be done as early as possible. So this was just a brief overview of the prostate cancer. I hope that this information will be helpful for the delegates.